Hello everyone. So now we have a patient, 34-year-old man, and he has complained of dizziness and palpitation in the crowded place. He is executive who travels frequently and reports high stress level. His BP is normal, pulse is also normal. The liver span is 8 centimeter, that is quite normal. Spleen not palpable. No cervical lymphadenopathy or skin rash. Lab results, platelet count is reduced. This is normal. HB level normal. Even this is also normal. That means we are only getting low platelet count. And this has been confirmed by the peripheral smear, which only shows reduced platelet count without clumping or malignant cells. Most appropriate next step for this patient is, well, the answer to this question is HIV antibody testing. Why? First of all, we got to know in the history, he is a executive, lot of stress in his work, and he travels a lot. Well, these themselves could be a reason of HIV, okay? Well, but now why we are thinking this patient, let's talk more about. The patient presentation is of isolated thrombocytopenia because only platelet count is of 80,000 per ml. RBC count and leukocyte count are normal. So we can say there is an isolated thrombocytopenia without anemia and leukopenia. And it suggests that we are dealing with ITP, idiopathic thrombocytopenic purpura. But before I discuss this, let me ask a question to you. Stop the video, write down the answer. What do you mean by pseudo thrombocytopenia? Stop the video. Well, the answer is also known as spurious thrombocytopenia. Definitely, it's an in vitro sampling problem. That means there's no problem in the body as such. But when we take blood sample, in vitro means in the glass outside the body. This may lead to misdiagnosis of more critical condition of thrombocytopenia. Why this happen? Definitely, when we are taking a blood sample, anticoagulant are used, especially when you are taking sample for CBC, complete blood count, where we use anticoagulant. In such situation, the blood testing, they lead to clumping of platelet, and that lead to reduced low platelet count. So what we can say other way around, it is all anticoagulant induced clumping of the platelet, and that gives a false reading of the platelet count. Well, as far as ITP is concerned, it may be primary, so-called idiopathic. It is usually autoimmune. Idiopathic. But it could be secondary to maybe HIV, hepatitis C, CLN, and SLE. There are some of the important causes of isolated thrombocytopenia can be occur in this case. Well, in our case, we are thinking about HIV. Well, so when we make a diagnosis, like in our case, we have to exclude all possibilities, important possibility, by taking history. Like in our case, history is important. He's a young man, travel history, stress. Other important clue in the history. Physical examination, we have seen no spleen, no lymph nodes. Complete blood count we have seen, and peripheral blood smear is low platelet count, that we know very well. So now again, before I go discuss this question in detail, let me tell you important cause of thrombocytopenia, the basic concept. This you should know very well. Basic concept. It could be due to decreased platelet production. This occur in viral infection like Epstein-Barr virus, hepatitis C, this and HIV. Like in our case, we are thinking of HIV. This is all due to decreased production. Chemotherapy is a very important cause, but in this there can be leukopenia and there can be low RBC count also. Myelodysplasia, this especially when we are getting a patient of above 60 years, but our patient is below 60 years. Alcohol use, chronic alcohol use can lead to this problem. Congenital like Fanconi syndrome, B12 and folic acid deficiency. Remember, B12 deficiency can even lead to pancytopenia. Can occur in B12 deficiency patient. Now, increased destruction, SLE, medication like heparin and anti-phospholipid antibody syndrome, ITP, idiopathic, DIC, TTP, thrombocytopenic purpura and hemolytic uremic syndrome. In all these conditions, there is increased destruction of platelet occurs. Well, dilutional due to massive blood transfusion, it's quite possible that a patient has been given large amount of blood that will lead to dilutional type of thrombocytopenia. Splenic sequestration, which classically occurs in a special situation. Stop the video, write down the answer in which condition we get splenic sequestration. Write down the answer. Sickle cell disease or so-called sickle cell anemia is a cause of splenic sequestration. Well, we come back. Thrombocytopenia may be a presenting finding in up to 10% of patients with chronic HIV as well as hepatitis C. Very, very important causes. Don't forget these two. So, any patient where we are getting isolated thrombocytopenia, do not forget to investigate for HIV and hepatitis C also. Okay, because if you treat the basic cause, the platelet count will automatically improve on getting the proper treatment. Bone marrow biopsy may be required in patients with negative tests and unexplained thrombocytopenia. You have done all the investigation, ruled out antibodies, and if you are not getting, then you think about going for bone marrow, otherwise not needed. Now, again, I have one more question. Stop the video, write down the answer. We talked about chronic HIV where thrombocytopenia can occur in as high as 5 to 10%. So now the question is, what are the other important features of chronic HIV? Stop the video, write down the answer. Well, the feature in chronic HIV are oral candidiasis or hairy leukoplakia, aggressive seborrheic dermatitis, peripheral neuropathies, unexplained weight loss, generalized lymphadenopathy. Okay. Well, it may just come with fever of unknown origin or what we call as pyrexia of unknown origin, disseminated herpes zoster, opportunistic infections like pneumocystic, Kaposi sarcoma, B-cell lymphoma or unexplained cytopenias like maybe thrombocytopenia also. Let's look into other option. Option A, blood folate level are used to diagnose folic acid deficiency. They cause, remember, folic acid deficiency or B12 deficiency both can lead to pancytopenia, anemia, thrombocytopenia and neutropenia. All three penias can be there. But in our case, this platelet count is reduced, rest are normal. Okay, rest are normal. So this is unlikely. Well, moreover, in such cases, you make a peripheral smear and you get a type of megaloblastic anemia, macrocytic anemia, and there should be hypersegmented neutrophil nucleus are there to support your diagnosis that you are dealing with folic acid or B12 deficiency, but these are not there in our case. Look into this, lovely. This is hypersegmented neutrophil nucleus. The number of lobes in nucleus are 5 or more than 5. You can see plenty of lobes are there. CT scan, this is expected to see for the splenomegaly. But in our case, spleen is not palpable. Okay, so whenever we are suspecting splenomegaly in a splenic sequestration of platelet, cirrhosis, portal hypertension also. However, this patient does not have any splenomegaly or stigmata of liver disease. So this is ruled out. Let me show you some stigmata of the chronic liver disease like this caput medusae, dilated veins around the umbilicus, spider nevi, central arteriole with radiating thin vessels, gynecomastia, enlargement of the breast in a male patient. Let's look into other option. Epstein-Barr virus, also known as HHV4. Its titer are very useful in diagnosis any case of Epstein-Barr virus. And this is classically lead to infectious mononucleosis, so-called kissing disease, which typically occurs in young people. Patient come with fever, sore throat, fatigue. Palatal petechiae is something unique finding. Posterior cervical lymphadenopathy, again something unique. Splenomegaly is there in such cases. Well, there are two more questions for you. Stop the video, write down the answer. Epstein-Barr virus infect B cell through which CD marker? Which type of cells are atypical lymphocytes? Just to remind you, in infectious mononucleosis, there is absolute lymphocytosis. Okay. Well, I hope you have written the answer. It infects B cell through CD21. And we see atypical lymphocyte on peripheral blood film. And they are not very something unique. They are not B cell. They are reactive cytotoxic T cell. Point to be noted. Well, we diagnose by monospot test. It is a heterophil antibody detected by agglutination of sheep or horse RBC. So this is regarding atypical lymphocyte. They are T cells. Look, they are typical. Large atypical lymphocyte. You can see the normal lymphocyte. You can look at beautiful comparison you can do. Just to remind you, they are T cells. Now, as I told you, labs it showed lymphocytosis. There can be thrombocytopenia, can be there. And regarding lymphocytosis, I told you it's a type of absolute lymphocytosis. Well, so now in this patient, there is no other finding other than thrombocytopenia, so Epstein-Barr virus is ruled out. What about rapid plasma reagent test that we do for screen for syphilis? Congenital syphilis can be there with stillbirth, anemia, and thrombocytopenia, but that is congenital. Our is a young man. Syphilis in adult does not lead to thrombocytopenia, and moreover, nowadays syphilis incidence has gone down drastically, okay, as compared to previous because of better diagnosis and better treatment. Golden line to remember, ITP is usually diagnosed with excluding other possible cause of thrombocytopenia, especially in adults. Patient usually be tested for hepatitis C and HIV. Thrombocytopenia may be there in about 5 to 10% of patients with HIV as well as hepatitis C. If you treat the basic cause, the problem will disappear. Thank you very much.